From Sarasota Memorial, this is HealthCast. A healthy dose of information from experts you can trust.
Hi, everyone. Welcome to HealthCast. I'm Allison Warren. In light of the news surrounding COVID-19 locally, nationally, and internationally, we're changing up HealthCast a little bit to focus on the need-to-know information about this pandemic. Joining me today is Dr. Manuel Gordillo, an infectious disease specialist and the medical director of infection prevention and control at Sarasota Memorial Hospital. Dr. Gordillo, thank you so much for being with us.
Thanks for having me.
So, Dr. Gordillo, you guided the care of COVID patients in our area and helped prepare the emergency response at SMH from the very start of this crisis, even before the crisis. So can you start by telling us how you and the team went about addressing the virus before it even made its way to our community?
Oh, yes. So in epidemiology, we're always looking for epidemics that have the potential to become a pandemic anywhere in the world. So we're doing this all the time, and we've had a lot of experience with this just this century. We started in 2002 with the first SARS, which was a coronavirus. Subsequently, in 2009, we have H1N1 influenza that started in Mexico. Then subsequently had MERS, another coronavirus that started in the Middle East. Then we had the 2014-2015 Ebola that started in West Africa. More recently, Zika virus in Brazil. And so we're constantly on the look for this type of things. As a matter of fact, one interesting piece is that in December, at the beginning of December, we got invited by a group of scientists from MIT and Harvard that came to Sarasota Military Academy to do an exercise on a simulation of a pandemic. And they had created a virus that turned out to be coronavirus for the kids in the school to discover what it was. And during this, actually turned out to be very provocative in a way, because the virus that they have created was mutated MERS virus that was highly transmissible. So just for serendipity, we were already practicing some of these pandemic situations in the month of December. So later on, 3 weeks later, we started hearing about an outbreak of pneumonia in China. So we immediately, our radars focus on that area of the world, and we started following what's happening there. You know, an epidemic of pneumonia anywhere in the world is of a lot of interest to us. We started watching that, and then, as you know, it evolved as the big outbreak that happened in the province of Hubei in China, in Wuhan. And by January the 20th, we already had the first case in the United States in the state of Washington. So that we had been talking within our group in infection prevention and control and following carefully this. When the first case occurred, that's when we decided that we had to call the rest of the hospital to prepare for this and initiate our more serious work for this. And then later on, the next month is when we started seeing the first case. I happened to be one of the doctors that saw that first case. And the interesting part was that unlike most other cases that had occurred in the United States, it was only the second one that did not have a travel history. So that immediately gave us the signal that this case was already, that this virus was already transmitting itself within the state of Florida. So that even raised the alarm much higher, and we started doing more a wider approach to this. We had to implement a lot of protocols to detect the virus and go from there.
Now, you actually diagnosed that first case. What has it been like in the hospital setting since? Because this has been a rapidly evolving, rapidly changing set of circumstances.
Oh, extremely rapid. You know, and that's a problem with viruses, is that nowadays they can travel so fast throughout the world. In no time, had spread probably all the continents. I think the only continent that initially was not affected was Antarctica, but in no time it was spread throughout all the continents and in most countries. So when we knew that it was in Florida, we had to start doing all the things that we have been preparing for. But basically, initially with the hospital, we needed to have protocols to identify cases and isolate them. Those are the keys, because we didn't identify cases, we didn't isolate well. There was going to be a rapid spread in hospitals. And in hospitals, when there's rapid spread, they become amplifiers of the epidemic. And this is something that we did not want for our community, did not want for our hospital.
How has your view of this virus changed from the time you first started hearing about it, as you were talking about in Wuhan and in China, and then it came here, and now we've seen that community spread? How has your view of the virus changed?
Well, our worst nightmares turned out to be reality and true. When we started seeing what was happening at the end of December, early January in China, we thought, wow, this is something different. But we have seen it before. Sometimes that happened in SARS. Cases were dramatic. They were causing a lot of mortality. But then, for a number of reasons, the pandemic did not progress. For seasonal reasons, because there was some preparedness wherever it was attacking, and the characteristics of the virus were such that we're able to be controlled. This virus, however, turned out to have very difficult to control features. One of the things that we found later is that transmission can occur before the patient shows symptoms, and it's highly transmissible at that time, especially right before the patient starts displaying symptoms. They can be very transmissible. So that's one of the things that make it very transmissible and contagious and difficult to detect. Therefore, we started with that, not in our equation, but as things progressed, we started learning about those things, and then we started learning about the wide manifestations from a clinical point of view. We thought that this was a respiratory virus, but then we started finding out that it not only affects the respiratory tract, but it has a lot of vascular issues and cardiovascular. And then as things go along, just about every organ in the body gets compromised by this virus, and results, at least in the cases that we see in the hospital, which are, of course, the more severe cases, probably not the majority of the cases, but this gave us an idea and a glimpse of the severity of illness that this virus can cause.
Now, there's been a lot of discussion as of late about testing. We've heard about antibody testing, antigen testing, questions surrounding the accuracy of certain tests that are available. Can you just tell us a little bit more about the tests that are more readily available in our state and in our region, and what do people being tested need to know?
So there's, in general, there's two tests that are available now. The molecular testing that detects the molecule of the virus, which in this case is an RNA, and those sometimes people call them the PCRs, for polymerase chain reaction. And generally, those are obtained from the nasopharynx, so they need to get a swab through the nose to the pharynx. Those are the most reliable tests that tell us if you are harboring the test in your body, in this case, the nasopharynx. That's the most commonly done test. Sometimes not as good as this one, at least for now. They can do the oropharyngeal test, and sometimes the nose. In the future, we're probably going to have other places we can sample. Specifically, saliva seems to be one that in hands of some investigators seem to be an easy place to obtain a sample, because obtaining a sample from the nasopharynx is still technically challenging. and it's logistically demanding. That's for the PCR test. It's very accurate. It's a molecular test. However, it's difficult. It's expensive. There's a lot of logistical challenges in obtaining that, and also there's some issue with the throughput, the amount of testing that we can do. When we're talking about hospitals, yes, we can handle hospitals. Over time we've been increasing our capacity to test in hospital, but when it comes to the needs of the community at large, then we're talking about much larger numbers, and that becomes difficult, and that's where we need to work on decreasing the logistical barriers, increasing the throughput. Now, there's another kind of test that has become very much in the news lately, which is the serology, the blood test, so to speak. That detects antibodies against the virus. And there's a couple of antibodies that is most commonly detected. Something's called IgM, which is an acute phase, and then IgG, which comes a little later, but it persists for longer. So this is basically the memory that our body, our immune system does when they see a virus. For instance, this is what we normally do to diagnose measles, who has been exposed to measles and those type of things. Now, this test has some promise for some things, but the problem right now is that there's not that many people infected in populations. Let's say Sarasota, for example. I estimate there's 2-3% of the entire population has been infected. That means still 97% of the population has not been infected. So if you start testing people that are mostly negative, a positive test will give you a lot of false positives just because the population tested has a very low prevalence of that. You mentioned the antigen test. That has been talked about as well, but we didn't have a test until this last weekend where the FDA has approved the first antigen test. We don't know the characteristics of the test. In general, if we look at all respiratory viruses, antigen tests are not as good as, let's say, a PCR test, but they're easier to perform. Usually it's a nose swab. In places where we don't have testing, that may be something that can come to our rescue, because it'll be an easy test to do, and it may be more easily available.
I want to talk fact versus fiction right now. There's been a lot of misinformation spread, because this has been that rapidly evolving situation. Some misinformation has been spread within good, accurate information online, on social media. What are the most concerning things you see being spread, and what do you wish people really knew?
Well, there's two general problematic areas that are very ripe for misinformation. One is treatments that are completely ineffective. We have, for this particular virus, we really don't have a lot of treatments that are proven. Just recently, the remdesivir study has been released. It is a beginning. It seems to be effective, but still early days. The drug is not widely available. The Gilead, the company that makes it, has donated all the 160,000 vials or doses of this that they had to the government, and the government is distributing to hospitals as the need arises. But that's the only proven case therapy that we have. So there's all kinds of treatments that are coming down the pike that may or may not be effective, but especially online, in social media, or even sometimes in the regular press, there is a push for some drugs or forms of therapy that are definitely not effective and can be dangerous. That's one area. The other one is the conspiracy theories. And the conspiracy theories have always existed. Even probably you go to the Black Death, people probably they were talking about the Black Death in the conspiracy context. And every time we have a pandemic, there is conspiracy theories. I think what has changed is now how this can be amplified and disseminated. It's so much easier to do it. And then we are starting to see more sophistication, so to speak, in the way these are presented. We're getting professionals and doing videos and those type of things. And as you said, because this is a new virus, because scientists don't necessarily know the answers to all the questions, that's when conspiracy theories, they like to get into it and try to explain something that is difficult to explain in a way that sounds rational to most people, but these are generally areas where we have to intervene, in the sense that we need to try to have always science prevail, and this is a difficult issue. It is for me, and I'm sure for folks like you in the media, it is also difficult to deal with. And that's something that we're going to have to learn. It's a work in progress.
So states are now beginning to reopen. Even here in Florida, we've started to reopen, the phased reopening, but people always ask, when can life go back to normal? Is it really possible we're ever going to fully go back to normal, or is there going to be a new normal post-COVID-19?
We're not going back to normal until we have a vaccine, or until the population develops herd immunity, meaning when the virus can no longer keep infecting people because most of the population has become immune. So that's not going to happen until that time. Now, how do we manage that is going to be important too, because the virus has not changed. The virus doesn't mutate. Well, it mutates, but it has minor mutations that are not important. Humans' gene composition hasn't changed. Our immune system hasn't changed in a small period of time. Yes, there may be some seasonality to some of every virus that we produces respiratory infections tend to have some seasonality. In certain seasons, it is more active than others. But we have seen this virus in the southern hemisphere where it's hot. We've seen it in the northern hemisphere where it's cold. There's a variety of humidities where it has thrived. So I don't think that's going to change a whole lot. So we really have to be very careful. And I don't think it's going to change much until we either have the vaccine or we develop herd immunity.
What has COVID-19 taught infectious disease experts like yourself, and how do you expect it to change the study of viruses and pandemics in the future?
So much. I think that the key is that a pandemic virus anywhere, it has to be followed, and we need to pay attention. Not because they're in remote places of the world, we have to say, well, it doesn't affect us, because it can affect us, either because of the way the world is today. We are so interconnected and we can move around the world very fast. These viruses, especially that are transmissible, they will move around, and this influenza does it every year, seasonal influenza, and viruses like this, coronaviruses, and many others that we don't even pay much attention because we're so used to all those parainfluenza, respiratory syncytial viruses. They go through the world every year. It's just that this is a new one. Our immune systems are not used to it, and we're going to be dealing with this for a while until we have either vaccine or immunity. But the viruses need to be attacked at wherever they're happening, and unfortunately this tends to be happening in the wild. For instance, this is a bat virus and it happened to be in China, but there are other viruses out there like influenza, which can be living in birds, and we need to study the bird influenzas and how those can be jumping into humans. But then we need to start there. We need to understand what those viruses are doing there. Are they mutating? Are they becoming adapted to humans? And those type of things that we need to learn. Obviously, we don't have the tools to do those kind of studies. They're difficult to do, and generally the world is not prepared to start doing that. But in the future, we'll have to do that because that's the only way to detect and intervene if we're going to be successful.
Dr. Manuel Gordillo, thank you so much for joining us.
Thank you.
So thank you everyone who's joined us for this important episode of HealthCast. For more information about COVID-19, visit smh.com/COVID-19 to get the latest news from Sarasota Memorial Hospital.
Thank you for joining us today. For more information, please visit smh.com. Follow us on your favorite social media network.